Hey, this is Emily. I'm recording again. I just had to redo the whole video that YouTube did not want to record. Anyway, so for this week, Unit 8's blog, we're going to talk about different things like core measures and clinical pathways and things like that. So, one of the first parts that we're asked to address is, does the facility in which you work track core measures for community-acquired pneumonia, congestive heart failure, or myocardial infarctions? And the answer to that is yes. I know that we do, and I feel like, in fact, in order to be compliant with Joint Commission, that's something that we are required to do in order to stay open. And we do track these things. I know it's because we've got chart abstractors who that their sole job is to sort through something like 30 to 60 charts a month, and in order to, and these are 30 to 60 charts of people who have had congestive heart failure, myocardial infarctions, pneumonia, whatever the core measure is that they're looking at. They have to go through and check and make sure that all the requirements sent forth by the core measures were followed, that were completed, and if they weren't, that gets compiled into data, into like performance improvement data that gets sent out to the departments in order to be able to re-educate us, and as well as the physicians as far as what we need to be doing in order to be more compliant with the core measures. Again, the pneumonia, the heart failure, and the myocardial infarctions are not something that I necessarily deal with because I am on a post-surgical floor. It does happen, but those who are being treated primarily for those things usually go to the ICU or the telemetry or the medical floor. So these specific core measures, I don't necessarily work with, and I don't really know what's involved in them. But I just know that we do track them because I talk to the case managers and the chart abstractors. One of the questions was, does my facility follow critical pathways? And the answer is absolutely. According to Markey and Houston, their 2012 textbook edition, on page 215, it says that clinical pathways are a strategy for assessing, implementing, and evaluating the cost effectiveness of patient care. And so what these do ultimately is that they predict how long the length of stays should be for certain diagnoses, and they also dictate what interventions need to be done on what days. And this is to set forth a standard of care. And it's also to help make the care more efficient, I think, in a shorter period of time. And from what I understand, if people stay longer than the predicted length of stay, unless there's a good reason for them to have stayed past the predicted 4 days or 5 days or whatever is allowed, the hospital eats that cost. And so we have to make sure that we are following these pathways to the T in order to ensure better patient outcome. And so things like that, at least on my floor, we take care of a whole bunch of different surgeries, including joint replacements and things like hips, shoulders, and knees. And knees and hips, I believe, are given 4 to 5 days, I think, as part of their DRG. And if they stay beyond that, again, they have to have a reason. It can't just be like, I don't feel like being discharged today. Let's stay another day. Like, that doesn't fly. They have to go, or else we don't get paid, which ends up making people sometimes feel like they're being discharged before they're ready. But I mean, legitimately, if their pain's not being controlled, or if they're going home to an unsafe situation, then of course we'll keep them. We have to work with them, but we have to stay within the pathway as much as possible. Have I seen an improvement in care due to these pathways? Absolutely, because one of the things that we have to do as part of our pathway for I think it's any post-operative patient now, is that Foley catheters have to be taken out within on post-op day 1 or post-op day 2, and because of this, there are fewer urinary tract infections, and also if we follow the pathways for post-operative patients, it means we're getting people up and ambulating very soon after surgery, sometimes within a couple hours after surgery, or even sooner than that. And it improves care in the sense that it also improves patient outcome, because these people, when you walk, you do all that, you prevent all sorts of kinds of complications like pneumonia. You can prevent small bowel obstructions, ileuses. Sometimes it actually does a form of nausea and pain controls to get up and move. So I would say that it is an improvement in care. But as far as care specifically related to the core measures mentioned in our assignment, like the community-acquired pneumonia, congestive heart failure, myocardial infarction, again, I don't really see those that much, so I couldn't really tell you. But again, you would see those being implemented, and you'd see the improvement in the ICU, in the telemetry floor, and on the medical floor. The last thing that's asked is, in light of the healthcare laws that are discussed during this and previous week's discussions, what financial impact might performance measures have on hospitals trying to abide by the law? There's a huge financial impact now, especially now with things being changed up with Medicare. If we don't follow the recommended or pretty much dictated guidelines as far as what interventions to do when, we don't get paid. And we don't get paid for services that are being rendered regardless. So things like, I come back to the catheter, saying it has to be pulled out in post-op day 1 or 2. If we don't pull it out then, and we don't have a good reason for pulling it out, then we don't get paid for a portion of that stay. Also, Medicare is now saying, well, we've always known that a quiet, restful environment is more beneficial to healing and things like that. So now, if hospitals are too noisy, we're not going to get reimbursed. Things like that. So if we don't, basically, Medicare and Joint Commission and whoever else set forth these standards with the ultimate goal of improving patient care, and if we don't follow them, that means we're not giving the best care that we can. And and because of that, it's like you don't give a toddler, this is a terrible analogy, but you don't give in to a toddler when they're having a temper tantrum. You don't give them the thing that, I don't know, basically they're not going to pay you for giving substandard care. That's a better way of putting it. So that's their way of it's a financial motivation. If you don't do a good job, you don't get paid. If you do a good job, you get the money that you're supposed to get. So it is kind of a big motivator. So other than that, I hope that answers all the questions. You all have a good week.